Thank you. Just following on from Professor Lopez's talk, I suppose what I'm going to be discussing will be more about clinical practice and applying pharmacology to the treatment of the patients. It was quite interesting hearing Professor Lopez, especially in relation to the advanced practice nurse and how they are now starting to go into prescribing in many countries and also other countries following that lead. But also looking at the future and a lot of the robotic technologies. For my area, which I'll talk about in a second, pharmacy is sort of on the cutting edge in relation to the pharmacology and the drugs themselves. But there's still a whole lot of focus which has to be made of how we use the existing knowledge we have about the gene and practice or apply the gene technology and the genome projects, precision medicine into practice itself. So what I'm really here today to do is talk to you about how modern pharmacotherapy and also more traditional pharmacotherapy can be used by nurse practitioners and the advanced practice nurse in practice itself. So some of you may wonder why a pharmacist is here to talk about pharmacotherapy to a group of majority of nurses here. I basically teach into the nurse practitioner program at the university, and I'm the lead of the pharmacotherapy section into that program. And I suppose I have a vision that the nurse practitioner, when they leave any of the programs, and the advanced practice nurse has an understanding of the pharmacotherapy, how the drugs work, the adverse effects of those drugs, mechanism of action, and then how the nurse practitioner or the advanced practice nurse can go and talk to doctors in relation to the management of those particular patients. So this talk will be focused around the patient, the medications, the outcomes, and also a little bit of introduction in relation to prescribing. I will focus, or some of the slides are focused on the experience in Australia, but those experiences are very applicable across the world. But I'll be happy to talk to people from many of the other countries which are represented here about some of the differences in their jurisdictions. So we all talk about patient-centered approach. Now I won't talk too much around this area because I think you as nurses much more focused around patient-centered care than traditionally pharmacists have been, and some of my colleagues may not agree with that, but I think pharmacy has been focused a lot about the drug, the science, what happens, and then we leave that little bit of patient-centered care for other people, and we're now catching up to where nurses are leading the area of patient-centered care. But I suppose what I wanted to bring you back to is the area of making sure that the treatment of the actual patient is at utmost. So exactly what are the needs of that patient in the either acute or chronic care situation. So in Australia, which I think, well, I know that the data is very applicable across all the Western nations, and I suspect, and I must admit I haven't looked at the data in some of the Asian countries, that the medication errors are very high, and they result in a significant cost in relation to readmissions in hospitals. And I suspect that's a worldwide trend across the whole world. And you can see it's a significant amount of money which is spent on solving these medication errors. When we think about patients, about 80% of patients will receive some sort of drug in their treatment, whether it is basic paracetamol or whether it is more the complicated biologics in the treatment of their conditions. They will receive some sort of medication. So therefore, both the nurse, the pharmacist, and the doctor will all be involved in the management of those patients with medications. And errors, as we know, can occur. Now, In Australia, there is a quality use of medicines strategies and the National Medicines Policy. This is absolutely applicable across all your countries. Most countries do have a National Medicines Policy or they're developing National Medicines Policy. And part of those policies is around quality use of medicines, or some countries will talk about rational drug use. And it's about selecting drugs by considering the place of medicines in the actual treatment and the management of that illness, maintaining health, but also to have an idea or a recognition that maybe there could be other ways of treating patients and managing patients. So medications are not the only focus of the treatment of these or management of these conditions. So a lot of the traditional approaches, natural therapies must also be considered when we talk about quality use of medicines. So when we look at medicines themselves, we basically look at the choice of the medicine, to look at the patient themselves. And I think that's when we come back down to patient-centered care. You need to take each individual patient by themselves to look at their physiology, the pathophysiology, their wishes, what they would like to use, understanding the mechanism of action, the adverse effects in particular. And some patients may decide that treatment A may not be the best treatment for those conditions. We need to look at what are the clinical conditions which the patient may be in, the risks and benefits, the dosage, the length of treatment, all factors which come down to the patient's wishes. Obviously, sometimes patients may not be in a situation where they can make decisions by themselves, and maybe they need other carers, etc., which will help make some of those decisions. But you can see that the advanced practice nurse has a significant role if they understand the pharmacology of these drugs, are actually able to help carers and the patients understand what are the consequences of these treatments. And you can go down that list, and I suppose the second last point in relation to monitoring considerations. Pharmacists in general, and this is worldwide, and it does change, taking from more of a Western perspective, that we do visit, apart from probably the States and maybe Canada, we visit hospital wards as a pharmacist through the normal daylight hours. We have on-call services, but we don't always have a 24-hour pharmacist. Nurses and advanced practice nurses are there 24 hours a day. So many of the monitoring processes in what you do on a daily basis, and you do extremely well, could be related very much with the drugs they're taking, and most of you do that, and then report back to the doctor. And what I see is the nurse practitioner and the advanced practice nurse actually has a little bit more fundamental knowledge, I could say, to take that information. So when they're making recommendations to the doctors, they're actually saying, well, okay, this is high, this is low, this could be a possible cause of it. You need to consider this, this, and this. And many of you are doing it, but I think when we look at curricula, that is extremely important, or that fact is an extremely important part of the modern curriculum. And obviously there's a cost and cost benefits of appropriate QUM. So again, we look at medication safety, and medication safety and patient safety is utmost in all of our minds, whatever health care profession you are. And what we're looking at is monitoring the outcomes, actually looking at the overuse, misuse, underuse of medications. Many of our patients, when they leave hospital, so I've been sort of talking about more acute settings, when they leave the hospital, they're in a situation where they're going to pharmacies, they're going to outside healthcare, other alternative or traditional providers of treatments, and they're using a lot of medications. Those may interact with what has been prescribed from the hospital in the acute setting. So we need to think about how all that information can be ferried back to the managing physician and also the doctor or the general practitioner as well for that patient. We know that we've got an ageing population. We know many, Japan, Korea have starting to get, to the oldest life, or the longest life expectancy, I should say, in the world. And we're in a situation that all our patients are getting older. The amount of drugs the patients are on are significantly increasing. The possibility of interactions is also increasing at that rate. So it is going to be a significant issue in the future as we move forward over the next few years. We have, just for the pyramid, and I'll quickly go through this before I get on to the case studies here, all I wanted to get you to think about here with this slide is to think that there's a level 1 awareness of knowing that pharmacology is an issue, or pharmacy is an issue, medications are an issue. Then obtaining the appropriate knowledge and skills, and then going on to actually action evaluation, which includes the monitoring, quality assurance. I would say in Australia we've got key initiatives look at patient safety. Every other country, or I should say most other countries, have similar initiatives. What we need to do is work out how the nurse practitioner, the pharmacist, the doctor, and all the other allied health services can all work together in this particular area. I'm proposing, and it's, in a way it's not unknown, and most of you will be saying, well, I've heard this all before, but it is important. We need to understand the patient, we need to understand the medications, and with the medications, this is the pharmacokinetics of those drugs. So what does a patient do to that particular drug? So the absorption, distribution, metabolism, and excretion. And coming up, I'll show you a couple of examples which highlight the importance of understanding those kinetic processes. Most of you, if not all of you, in your training would have had a lecturer come up and say, pharmacokinetics of drugs, and probably very similar to my students in pharmacy look at kinetics. Oh yes, I need to understand that to pass an exam, and then they may seem to forget it about 2 minutes later. So what we need to do is actually show the importance of this, and it's only when you're actually out in practice do you understand, in particular with metabolism. This could result in everybody's got, there may be differences in metabolism, especially with now therapeutic drugs, and that difference could result in toxicity or under treatment. And again, I would say that nurse practitioners and advanced practice nurses can be involved in picking that up. The responses, so pharmacodynamics, in other words, what does the drug do to the patient? And also looking at adverse effects. You all pick up on a daily basis adverse effects of drugs. The question I'd say is how many nurses and pharmacists actually have the depth of understanding about the drugs, which can actually say that adverse effect was caused by the binding onto whatever receptor, which has then resulted in this effect. So if I then choose or recommend that another medication which works by a different mechanism, you can actually avoid that adverse effect. So it's around the depth of that understanding. Now, in President Obama's State of Union address this year in January, he announced $215 million allocated of the budget, which is a relatively small amount, but it does highlight the importance in relation to personalised medicines. It's changed its title to be precision medicine now, and it was focused around oncology and understanding how genes affect the treatment of patients. So it's really targeting drugs and also the conditions of what drugs to use for an individual patient. And when we reflect back on Professor Lopez's presentation, that's really the future for us, is actually understanding this drug is going to do this in this patient, and it's going to be different in the next patient which you have to manage. So it is starting to become an extremely important point. So now I just want to quickly go through 3 cases and their summary of cases to illustrate a point. So I do acknowledge there may be a few little changes to them. So you've got a patient with intractable or not controllable angina, so significant chest pain. And the doctor says, I'd like to use perhexaline. Now, some of you would know what perhexaline is, some of you may not know with perhexaline. But perhexaline is a drug which came onto the market in Australia in 1978. It then got orphaned soon after. So in other words, it lost its sponsorship from the drug companies. In many other countries it was introduced even earlier, but then was taken off the market because of serious adverse effects. In the 80s, late 80s, getting onto the 90s, it was reintroduced into Australia and across the world because they did drug levels, and they discovered that with some patients they actually found that they metabolise the drug slowly. In other patients they metabolise it sort of in an intermediate speed, and then others were very fast metabolisers. So if they were slow metabolisers, it took a long time to reach steady state. The consequence of that, rapid changes in doses without monitoring, could result in very high levels, causing many of the adverse effects which are listed there. On the other hand, if they were fast metabolisers, they would get rid of the drug very quickly and they would be subtherapeutic. So here now you can extend, so in the late 80s, 90s, a lot of that research was done by just drug levels and understanding, well, the differences in patients and basically a trimodal distribution of metabolism. Now we can look at those specific isozymes and say, well, from the genetics, this person is going to be a fast metabolizer or a slow metabolizer or intermediate metabolizer, and therefore we can tailor that dose. We still have to operate clinically, and that's where nurses and doctors are extremely effective at understanding what's happening clinically. But if they're not being treated, you need to understand, are we going to increase the dose today, 2 days after we've discovered this? Are we going to wait another 4 days and wait until it reaches steady state before increasing it? Because you don't want a sort of cumulative scaffolding response which gets into toxicity. On the other hand, you don't want a yo-yo effect as well. So again, this drug, while it's not going to be a major drug to make the company a whole lot of money, it's got a huge position in practice. Now this case is sort of a made up, or it's a modified case I should say, not a made up case, modified case of a real patient. And here for atrial fibrillation, a patient was prescribed digoxin, and relatively old drug, but also the doctor has now added verapamil. So verapamil is a calcium channel blocker. Probably what's really important here is this patient's got reduced renal function, low potassium. And so this is a narrow therapeutic index drug. It, with digoxin, the dose can vary significantly with patients. It is a low dose. Many of you would know in the countries where the brand is Lenoxin PG, that the PG means pediatric and geriatric. So we've got an older patient. They're receiving the dose which would be seen as an appropriate geriatric dose, but it varies. But it's also metabolised and renally cleared. So therefore, if a person's got reduced renal function, they're going to accumulate the digoxin. But you add verapamil in innocently, what that will do is reduce the clearance because of inhibition of metabolism by about 70%. And therefore, you get toxic levels of digoxin, and which are some of the signs which this patient presents. And then we've got another patient. So that last case just illustrates understanding the pharmacology of the drug, and the kinetics is very important. And the final case is, and this is a little bit different, this is a real patient which presented with febrile neutropenia and has got ALL, acute lymphocytic leukemia. Now, I'm not sure if you can read those numbers very clearly, but probably what's important, I want you to focus on the creatinine, serum creatinine concentration. This is a young girl who's got a serum creatinine of 0.54 millimoles per litre, significantly high. And the question was asked to us, should we be withholding the dose of methotrexate going to be used because of that renal function? We asked the nurses on the ward what was the patient like, and they said, oh, she was like she normally is, running around the ward and being a normal kid who's coming in to get their next course of chemotherapy. We looked at the urea. We thought, oh, this seems very strange. It hasn't gone up. Renal function is, it's confusing. We didn't know what it all meant. We then looked back at the month before, and the renal function and urea were both normal, absolutely good. So we then thought there must be a problem. What has happened here? So we then recommended we do another sample, talk to the doctor, and we did a sample at 6 o'clock at night in there for this patient. We were still withholding all the doses, and what we discovered is a creatinine was back to normal. Exactly what we thought it would be. And I know a lot of you would now see EGFR, so we'll be seeing that same drop-off. We looked at uric acid as another component which would be renally cleared, and that was quite normal as well. And what happened here is the patient had received some dexamethasone injection into a central line. The sample of blood was drawn from the central line. Now, we spent a lot of time looking at structures and working out, was it dexamethasone which caused an error in the assay. We then looked up some drug information about the product literature, and we actually discovered that the dexamethasone injection is actually stabilised with creatinine. So creatinine is actually contained in dexamethasone injection. So what had happened, it was just an artifactual result caused by the line not being cleared. So again, you could make decisions wrongly on a number without looking at the clinical picture of the patient and finding out from pathology as well. So probably the most important parts here is what is the role of the advanced practice nurse? And it's really looking at the identification of the side effects, understanding pharmacology, advocating for the patient, collaboration, and also making recommendations. So we can do that by knowledge, communications, and monitoring. And I'll just quickly go through these. The most important part is I would suggest that this should be introduced now into curricula and also existing practice nurses. And many advanced practice nurses are doing this on a daily basis. But the depth of that understanding may not be as great as it could be in some cases. Nurse prescribing, in some jurisdictions it's occurring, and the outcomes are very positive, but it's not available in all jurisdictions across the world. And the others in relation to advanced practice nursing. And finally, it's probably important, it's following the WHO recommendations of every health practitioner developing their own personal formulary for the area they're working in. So if you're working in mental health, you would have a formulary and knowing the depth of all those drugs extremely well. And you may not be the expert in cardiovascular medicine, but you're an expert in the field which you're practicing in. Okay, so that's it. So thank you for listening to